Hi, good afternoon. Welcome to the session 4, bronchiectasis through the ages. I'm Alan. I'm a bronchiectasis patient. I was diagnosed 30 years ago, so I definitely have been through the ages. And I'm co-chairing the session with Dr. Oriol Sibilla, and he will introduce himself.
Thanks a lot, Alan, and good afternoon to everybody. Yes, my name is Dr. Oriol Sibilla. I'm a pulmonologist. I'm currently the head of respiratory department of Hospital Clinic in Barcelona, and I'm also an associate professor of the University of Barcelona. And I'm running a clinic in bronchiectasis, which is my field of interest. I'm sure we will have a very interesting session this afternoon. Focused on bronchiectasis through life stages. And we will start with Professor Ami Kanter from Italy. Ami Kanter is the head of the pediatric unit and pediatric cough and asthma center in Istituto Ospedaliero Bergamaschi in Bergamo, Italy. He's also professor at the University Via Salute San Raffaello in Milano. And in addition, Ami is co-chair of the Child Beer Net, which is the Children's Bronchiectasis Education Advocacy and Research Network. And he's also collaborated in developing the European Respiratory Society clinical guidelines on managing bronchiectasis in children. So Professor Kanter will talk to us about bronchiectasis in children, sharing knowledge with parents. So thanks a lot. Ami, it's your time. Go ahead.
Okay. Can you hear me? It's okay. Had you seen my slides? It's okay.
Yes, we can see your slides and hear you, Ami.
Okay. Good afternoon, everybody. I'm very happy to be with you today. And I'm very proud to be a pediatrician among all experts in bronchiectasis. It's a great pleasure for me to present our BearNet, Child BearNet, which was founded in 2 years ago, 2021. And my talk will be today about bronchiectasis in childhood. And this is our staff. These are the core of our CRC community. And we are very thankful for the heading of this community by An Chang. I think An Chang is well known for all of you. She is one of the most active members of our group, and she's one more of the active researchers in bronchiectasis. So as I told you before, our clinical research collaboration started in 2021, and this is our third year of working together with all our staff. And I'm very glad to say for you more that the members of our collaboration is increasing all worldwide, and we have a lot of people joining us from South Africa, from Israel, and other countries, which will help us to establish our aim. And I will explain for you what we are aiming for in this collaboration. So what are the main aims of our collaboration of this CRC? And you can see to build a collaborative international network of patients and parents of children with bronchiectasis. And in this case, we are very thankful also for Zena. She's very active in our group, and she's helping us to get in touch with many other parents with Janet. We would like to create standardized multinational bronchiectasis registries, and this is a very hard aim. We are trying our best to do it in some countries. We have been starting in Australia, in Greece, and in Turkey. And we'll hope soon we'll have other registries worldwide, so we can get much more information about our children with bronchiectasis. We would like to develop a quality standards document based on the RS guidelines to establish a standardized definition of respiratory exacerbation for clinical use. And some of these objectives have been already done. And to establish a consensus of core outcomes and points for the evaluation of bronchiectasis in children, as we can see, and for their parents. Now, this is just to show you some of the countries that have been already participating in our activities. But as I said before, much more of these countries have been joining us in the last year. So I would like to start with this sentence that Andy Bush has been wrote for us some time ago that bronchiectasis is a descriptive term and is not a diagnosis and should be the start, not the end of the patient diagnostic journey. And this is very important in childhood. We always try to find the reason behind this bronchiectasis. And this is not only maybe even children, but also in adults. But in children, our aim is to find as soon as possible, not to delay this diagnosis of the cause of bronchiectasis. This is a nice paper that had been published some years ago. Excuse me. And you see it's 1931 by Boyds that described 56 children with bronchiectasis, and he reported that the recurrent or chronic bronchitis to be the second most common cause of bronchiectasis in children. This is just an example for you that infection in childhood, some kinds of infection, recurrent infection, or chronic infection, as the case of chronic bronchitis, is one of the main causes of bronchitis. So at this point, we can think immediately that prevention in childhood of recurrent or chronic infection may be the best way to avoid some types of and phenotypes of bronchiectasis. There's another paper, it's written 1949 years ago, and you see that the author field, you see this clinical study of the pre-bronchiectic state in children have revealed that importance of organizing and adequately treating without delay certain predisposition before irreversible changes have occurred, leading to bronchiectasis. And here we can see the first idea that have been developed years ago that in childhood, bronchiectasis is maybe many times, and a good percentage of them may be reversible. And this is important to consider, that delaying diagnosis may lead to irreversible changes as mentioned in this paper. So what are the main causes of bronchiectasis in children? As you can see, this comparison between children and adults, and you can see that about 50% of children, they have idiopathic, and about 25% they have post-infectious causes of bronchiectasis. Other causes are well known for us as immunodeficiency and ciliary dyskinesia, aspiration, and some congenital malformations. What's good in this point to remind you that many of these idiopathic, what we consider idiopathic bronchiectasis, may be a post-infectious or unrecognized infection in early childhood that had been misdiagnosed or mistreated in the right way we need them. So you can see here, most of these cases like cystic fibrosis, dysregulated immune function, infectious diseases, structural congenital malformation, bronchial obstruction, and aspiration, inflammatory conditions, and some clinical syndromes are one of the main causes of bronchitis in childhood. Although many of these cases can be diagnosed early in childhood, unfortunately, sometimes adults, they find the same, they diagnose it in adulthood, which is a very bad thing for us, pediatrician, to misdiagnose this condition in early childhood. So our aim is to help pediatrician in any case to think about this diagnosis and not to discard the possibilities that recurrent infections and repeated infection in childhood, we must think about bronchiectasis in that case. This is slide have been shown many times, I think, today about the mechanisms and the pathogenesis of bronchiectasis. I think there's little differences between children and adults, but however, our aim is always to think that we must remove infection, inflammation, and the abnormal mucus from the airways. So our treatment aims are maybe very similar for adults, although we don't have the same evidence-based data like adulthoods they are getting nowadays. So leaving the airways all over the time clean is our hope. It's like cleaning our house. So you must have a housekeeper that clean the lungs of this subject of bronchiectasis every day. At every moment, we need to have it clean. And this, and some of this difficulty in doing this job is because of some congenital diseases, like the case of ciliary dyskinesia, or sometimes of some immunological problems. So in that case, we must think about replacing this activity of cleaning the lungs every day. So as has been mentioned today, even airway inflammation, mucus secretion, disturbance of the mucociliary apparatus, and the damage to the airways are the results of repeated infection in childhood or for some genetic abnormalities in the cilia or in the airways by itself. And sometimes we must think also about the role of social environmental factors like smoking, housing, and some environmental effects that may influence the damage for the airways. So when should a pediatrician think about the bronchiectasis? We should suspect it every time we have a child with a productive or wet cough that lasts for more than 4 weeks, and that although we have undertaken appropriate antibiotic therapy, didn't get better with the treatment, and the chronic wet cough persists. Bronchiectasis should be also suspected if your child has repeated episodes of productive cough for more than 4 weeks duration. And wild cough is the main symptom of bronchiectasis, and mainly wet cough in children. Sometimes children can also have other signs and symptoms, such as repeated pneumonia, coughing of blood, and shortness of breath. And such symptoms should be taken into consideration by the pediatrician always. We may not find some abnormalities in your x-rays, but this doesn't mean anything for the diagnosis. So it's ideal to identify the cause of bronchiectasis where possible, and this is to target appropriate disease management strategies. These strategies may also be associated with reducing the progression of the disease and even to reverse bronchiectasis. Just to give you a simple example, in the case of ciliary dyskinesia, here is a very nice paper, and you can find the terrible delay in the diagnosis in these children. So sometimes you may have diagnosis in the first days or first months of life. In other cases, it takes more than 20 years to reach the diagnosis. And this means you have a recurrent infections and easily formation of bronchiectasis. So the problem in childhood is not to delay the diagnosis. And pediatricians should be aware of this fact, that the earlier you have the diagnosis, the better you have the resolution of the bronchiectasis in these subjects and children. We have some problems, however, with bronchiectasis. And these problems are very clear for us. Just watching data coming from Australia, for example, where you can see that in Australian indigenous and non-indigenous adults, the difference is about of 22 years, where the former group dies up to 24 years earlier than the later one, the non-indigenous group. And this means that you need till now to have a very good health services for adults and for children with bronchiectasis. Another problem is that we don't have all over the world centers that take care of these patients separately. Usually these patients are being referred to cystic fibrosis centers, and this is for us a problem too, because they are at risk of further infection in these centers. So as you can see, it's not so easy to talk about bronchiectasis in children all over the world for some basic problem in our healthcare system, depending on the country. And here you can see the statement that our CRC group have developed, in which we confirm these statements, 7 important statements that confirm that we can only confirm bronchiectasis by chest computed tomography scanning, and that children and adults with bronchiectasis are thought appropriate airway clearance. And this is very important for us, I said before, because if we can keep the lungs clean all over the time, we can maybe reverse bronchiectasis. Children and adolescents with bronchiectasis with acute exacerbation are prescribed at least 14 days of antibiotics. Children and adolescents with bronchiectasis who have 1 or more hospitalization for exacerbation in the previous 12 months are offered at least 6-month trials of macrolide antibiotics and their response assessed. Children and adolescents with bronchiectasis have the minimum panel of diagnostic tests undertaken always. children and adolescents with bronchiectasis receive a special pediatric respiratory physician care, which I have told you before, and children and adolescents with bronchiectasis are reviewed at least 6 months by a multidisciplinary team. So our hope that this standardization of clinical care will help many pediatricians and many pediatric departments all over the world to follow up children with bronchiectasis. Now, one of the main problems of children who have bronchiectasis is exacerbation, and this attack should be well recognized by the patient and by the doctors. And as you see, in this survey I taken some time ago, patients and parents responding to the ELF survey rated exacerbation among the top 3 factors affecting their quality of life. So it's important that subjects, children, with bronchiectasis, to have their action plan, and you must ask the patient for an action plan from your pediatrician. Your action plan may be different from one patient to another patient, and a way it may include a prescription of appropriate antibiotics and criteria to recognize what to do in case of an attack. You should be able, as a patient, as a parent, to recognize an exacerbation. You should be able to evaluate the severity of this exacerbation. And by the last thing to say, you will be able to recognize the red flags or the alarm signs in case of a severe exacerbation. Now, maybe the treatment and management of this in children is based on recognition of these symptoms, and symptoms can be early recognized by the patient himself, such as fever or changing respiratory rate, wheezing, breathlessness, dyspnea, changes in the color and the consistency of sputum. And just to remind you, not all children are able to produce sputum. So you should be about 6, 7 years old to be able to produce enough sputum for us. Whereas from the medical point of view, we have a lot also of other parameters that will help us diagnose an acute attack on exacerbation. And this is what we have done recently. This is a recently published paper by our group in which we established what are the changes that we should use in our future studies and conditions to recognize an exacerbation. And some of these are clinical symptoms, others are radiographic changes, and others are based on spirometric measurements. And this is to recognize a severe and a mild exacerbation in children with bronchiectasis. Now, what's important for us pediatricians? Now, we know till the age of 20s, lungs are in continuous development. And during this phase of development, any damage to the lung, if it is recognized early and treated appropriately, is reversible. So our aim is not to arrive at the age of 20 with children with their lungs already damaged and with unrecognized bronchiectasis. And this is, I think, this is the main aim that we should all work together to do it. It is sometimes shameful to see that in adulthood, some early diagnoses that have been recognized in early childhood, reaching adulthood without any adequate treatment or misdiagnosed by other treatments. And this is the reason why I think that pediatricians are the main group that should take care of these children and be able to rise up alarm signs whenever we have a child with chronic wet cough lasting for a long time, or whenever we have suspicion of inhalation of a foreign body, or whenever we have a child with immunodeficiency, to follow it frequently. Just all of these processes can prevent having bronchitis in childhood. And as I said before, the problem is that these children, once they're over 20s, you know, their lung function start declining, and we should help them to reach adulthood with the best lung function, with their lungs as normal as possible, even above the normal levels of lung function. So whenever these measures are, these patients, early identification and treatment of conditions that may produce bronchiectasis, this is the best way we can help our children. As you can see in this slide, in childhood, as I said before, bronchitis can be reversible, and this depends on the early diagnosis and adequate treatment for various cases of bronchiectasis. So our aim, as I said before, to help the young lungs to grow and work as they should, improve the quality of life of people living with this condition, reduce the number of infections and exacerbation symptoms, prevent any additional complications in these subjects, and if possible, to reverse the damage in the airways. And if we can't reverse the damage, we can limit this damage to that area of bronchiectasis, rather than continuing forming new sites of bronchiectasis. So as it is well, we have hinted many times today about physiotherapy, the importance is physiotherapy in treating bronchiectasis. So it's good to teach these children from early age how to do physiotherapy. And this physiotherapy is also dependent on the age of the children. And as all you know, as a person gets older, the techniques and frequency of the exercise usually changes. And every time we may need different approach in their physiotherapy. This is a schematic review about how a physiotherapist should approach these children. Think about mucus problem. And as I said before, in children, it's very difficult to get sputum. So with positioning, expiratory flow modification, instrumental and devices that help them to remove mucus from their lungs, training for the respiratory muscles, and exercise intolerance being supported by physical activity and training. These are the main methods we use usually in physiotherapy, that, as you said before, it depends on the age of the child. So it's not only physiotherapy, it's not only treatment with antibiotics. We must think about other factors that are much important also, that in prevention, eating healthily and getting a balanced diet, getting enough vitamin D, keeping active through the regular exercise, keeping up to date with childhood vaccination. And just to remind you that unvaccinated children are much more at risk of developing bronchiectasis, like the cases of missing the vaccination for pertussis or varicella. And we need to advise the children to have annual vaccination with the flu jab, avoid smoking in the household and with their parents. And it's important for all other people in the house to practice regular hand washing to help to reduce spread infection in household. So the management is complex, and physiotherapy and antibiotic use is only one part of a complex overall preventive measures for these children. Now, lastly, I would like to talk something about school and children. Now, children with bronchitis may need to miss school for scheduled treatments or medical procedures, or they may be required to remain at home to reduce the risk of sickness in case of infections. A chronic health condition and its treatment can sap children's energy at times, making it difficult for them to give their full attention in class and complete assignments. So we need to also think about these factors, helping the parents and the child by himself. So pain and discomfort also is another argument. It's hard for a child to endure a long day at school and complete homework in the evening if he has been the morning in the hospital. So all of these factors have to be considered in childhood. And this is why we advise parents to maintain regular communication with the school regarding how your son is coping at school and trying to help him to overcome all these problems. Now, there are also something important about the quality of life of the children. Now, feeling of sadness and worry can diminish the optimism and drive need to do well in school. Children with chronic health condition may worry about their health perspectives, fear an upcoming treatment, or feel grief over the loss of physical abilities. As I said before, we need to support the family, we need to support the children. And this is a very important aspect in these children. If a child does not have a supportive group of friends and teachers at school who are aware of the illnesses and accept the child for who he or she is, feeling of being different can lead to problems with self-esteem and self-image. Chronic health condition can also be associated with depression and with stress, either of which can interfere with motivation, concentration, and healthy and sleep habits. So what we should do, we should provide a reassurance, but we honest, or they will not develop trust and open to you about their fears and worries. This is a good advice for the families and the parents. We should really reassure these children that they are going to overcome this period of recurrent infection or treatment. If they are going to do it the right way and the simplest way they can do it, they can achieve normal and as possible lung function and lung development. Now we know that kids are always concerned about what their peers are thinking, so you should always listen, be available, ask about their feelings. They should be given a very opportunity to continue friendship and other social activities. So at the end, I would like to advise you to get in touch with our website, and we will be happy to listen to parents and to the children themselves about their ideas, their sensation, their thinking, and about their symptoms and how we can help them every time. Thank you for your attention.
Thank you, Professor Kantar. A very interesting lecture and a very interesting talk, bringing about many of the points that equally apply in adults. And we're about to hear from now a teenager who started with bronchiectasis at that 8 months, but wasn't diagnosed until he was 8 years old. And he's embraced everything you said in this inspiring story about how children can cope and grow with bronchiectasis. Can you play Ed Powell's video, please?
My name is Ed, I'm 15 years old and I'm from Great Britain. I have bronchiectasis of the middle right lobe and I was diagnosed at the age of 8, meaning that I've had my diagnosis for 7 years. However, it's not always been as good as it is now. When I was younger, I didn't have a diagnosis and I was still ill, which really didn't help, especially as without a diagnosis it was very hard to get treatment for me outside of my consultant, as no one knew what was wrong with me. I initially started showing symptoms, so wheezing and coughing, at the age of 5 months old, and it took 7.5 years from that point for me to get diagnosed by my lovely consultant who works in Oxford. We have had, as a family, a lot of troubles trying to get this diagnosis. We've been told by one doctor that I would grow out of my condition by the age of 7 or 8, but that hasn't happened. I still got bronchiectasis now and I'm 15 years old, I'm double that age that he said I'd grow out of it by. And also we had another one who just wasn't interested in seeing me and caring for me because he was just interested in cystic fibrosis and that was it. Thankfully, due to the work that my parents have done, we've been able to get this diagnosis and persevere through. I don't really remember much from when I was young, but what I do remember especially is being told off by my parents for describing my cough as stupid. So they banned the word in the house because I used it to describe my cough all the time. So I decided to create a new word, toot, to describe my cough, which also got banned because I felt my cough was stupid. And at nursery at the time, which was the time this happened, everyone was going, "Oh, your cough's stupid," not in a bullying way, but in a way that was just a bit annoying to me. So I decided to use the same words to describe my own cough. When I was young, one of the things that I remember was that I couldn't go outside and play football and rugby in the winter like most of the kids my age, because I used to wheeze whenever I used to go out in the cold air. It was a thing that I had to deal with, unfortunately, but it did set me back slightly compared to my other peers who were doing those sports, but I was able to do other sports like swimming and squash, which led me to stay active while not having to expose myself to those conditions which were causing me to wheeze. It's a bit demoralising because I don't have cystic fibrosis. I'm very happy not to have cystic fibrosis, but because I don't, it's almost as if they can't do as much with me treatment-wise because there isn't the research or the funding into bronchiectasis as there is cystic fibrosis, which is a good thing, I guess, because there's less people with bronchiectasis, but still there's not enough funding for people like me to have the treatment and diagnosis that they need. Dealing with bronchiectasis now is different to how I dealt with it when I was younger. Now that I've got my diagnosis, I'm able to do my physio in a more free way for me. Running, cycling, playing the trumpet. Playing the trumpet has provided me with lots of opportunities. It's let me continue to do my physio, which I need to do to keep me healthy. Because one of the things that I really didn't like when I was younger, when I used things like the a cappella for physio, was the fact that it took time away from being able to do things. Whereas doing the trumpet, I can still do my physio, but also be active. I can be with my friends, I can make music, and that's something that I've found has really helped me. But I'm not able to do everything like my peers. There's some things that I just can't do because it's not wise for me to do it, but for others it may be okay. Things like camping in the damp, in the cold, are things that I just can't do. I did it once in year 3 at the age of 7 or 8, and I was ill after for around 9 months. My parents thought that I might not sometimes make it through the night because of the noises that I was making in my sleep. One of the ways that we've found to keep me healthy is to keep me active. So I run, I cycle, I play cricket in the summer, and all those things help with bringing up mucus that's on my chest. Also, I sleep on a wedge, which helps so that all the mucus doesn't drain from my lungs and wake me up in the night. He took months and years even looking at different tests and looking at x-rays that were taken when I was younger that showed an abnormality on my chest, but it hadn't been taken up by the radiologists or consultants that had looked at those scans and come to a decision on it. But yet he could see from just looking at it quickly that there was a problem there and it just hadn't been recognised. That was hard for us because the answers had been right there in front of the doctors, but they just hadn't picked it up. In the future, I hope to go into the field of medicine, whether that be as a doctor or as a pharmacologist or some other medical professional, because I really want to make sure that no child or adult ever has to go through what I've gone through and what my family have gone through to get a diagnosis and treatment. I also want people to understand through this that things will get better and there are steps you can take to make your life easier. I hope that what I've said can help anyone who has bronchiectasis with knowing that they're not alone and that the symptoms they have can and will hopefully get better in the future.
So thank you, Ed, for a very informative and inspiring talk. Congratulations for getting to play the trumpet at the Albert Hall. I can only feel jealous. Well done, good talk. There's now a question time that Dr. Oriel and herself will chair. So if any we're taking questions from the group, and I've been writing some of them down. And one of them was on the bronchiectasis drugs for children or for use in children. Could Professor Cantor answer that one?
Can you repeat the question, please? I was not hearing you.
Yeah. The use of what drugs are available for children with bronchiectasis relative to the adults with bronchiectasis.
Okay. Unfortunately, we have few research, with the new drugs that have been mentioned today in adulthood. So the main drugs we are using till now are antibiotics, and we don't have a good experience. We don't have evidence-based regarding mucolytic drugs. So our treatment is based on physiotherapy, antibiotics, and on treatment of the cause. In that case, in cases you have immunodeficiency and other causes of bronchiectasis, to treat the reason that stands behind bronchiectasis. But unfortunately, in childhood, we have a few drugs, and we feel that we need to concentrate our research for the future to find much more better drugs. But for the meantime, we can't just use other drugs in adulthood and childhood because we are not sure of their efficacy, and sometimes some drugs used in adulthood are not so good for children.
Yes, I'd like to. Yes.
Off you go, Dr. Ariel.
Okay, I'd like to congratulate both of you, but especially, of course, Ed. I think your video was amazing. If you see the chat, the web seminar is wonderful. What all the people congratulate you. And as a parent, I have an important question for Ami, because I have kids like at age. And the question was on the chat is, what about the smoking? Is paternal smoking a risk factor for the kids with bronchiectasis?
Surely it's a risk factor for infection. And this is what is the main reason we think about it. Smoking increases the possibility of infection in children, and we are always recommending to avoid smoking, even outside home. Out of the doors, because even in that case, you can have some effects on the child. And mainly in the early childhood, smoking is really terrible for the children. We know that it facilitates infection for them and may cause direct damaging. The same as vaping, which is terrible effects on the lungs. And we know that young adolescents are using much more vaping in their free time, and this is causing much more damages for the lungs of these children. So please don't smoke. If you have any type of, even if you have a healthy child, don't smoke inside your home, and try to avoid smoking. And this is especially in case of a chronic disease like bronchiectasis. Me too, I would like to thank Eddie for his nice talk. And I just to thank him not only for this nice talk, because Eddie and Zain are helping us in developing many activities, not only for patients, but also for us as a pediatrician. So Eddie and Zina, you are really wonderful. Thank you very much.
Thank you.
I think we have a break now. Jeanette?
Yes,
yes, we do. Yes.
Yes, we are on time. Yes, we have a break of 10 minutes. And in 10 minutes, we'll be back. In 9 minutes, we'll be back for the next video and the next presentation. Okay. So see you soon.
Yeah.
Hello, welcome back. And we're starting this afternoon's, this last session with a patient slightly older than Ed, but still a very interesting story, bringing out many of the points and frustrations of having bronchiectasis. So let's hear from Sandra.
received my bronchiectasis diagnosis when I was 48, which now is 8 years ago. And truly, I think my life has been split in two parts. The one before having this diagnosis, so before knowing that I was a bronchiectasis patient, and the one after. Since I was a kid, I always thought something was wrong with me, because I used to catch any kind of bacteria, virus, so I felt really weak. I mean, more than anyone else. The main problem is that I didn't know why. So after knowing that I am a bronchiectasis patient, finally I took control of my life. When I think about the past times in which I just wanted to know as much as I could, I loved going skiing, and so I took risks. I mean, didn't know that I was a bronchiectasis patient, and so I assumed that I could do anything I wanted. Now I can say that, of course, I look at the consequences, and for example, I keep still travel, you know, because I love traveling, but in the backpack I bring with me medicines. So I leave home high heel shoes, but I bring more paracetamol than anyone else. But I know that I can take risks to a certain, point, and knowing this make me in a way feel safer. It takes real much love from your relatives to stand your health issues. Only just doing physiotherapy and getting your mucus and coughing, they love me and they understand and they support. Family time sometimes is divided because, for example, I don't like and I don't want to go to shopping malls, and my daughter loves that. So it's a special dad and girl time. They go and they enjoy their time at the shops. I enjoy my time at home. I work for an international company, and they have programs for invisible diversities and disabilities. So I can say I'm really lucky, because I could ask, after the last pneumonia I had, I asked to work from home. Just going to work, so having to take public transportation, just having to deal with colleagues that sometimes would sneeze and have cold and say, oh, I'm not feeling well today, and you are there, suffering because you say, stay away. I mean, stay on your desk and don't have meetings in closed rooms. I mean, it was kind of stress that I often was in this pressure, because I knew that people don't realize. Of course, people tend to think that if you are home, you're not part of a project, you're not, you're not on a career. So I sacrificed that, but I earned my health. So to me, at this point, is more important caring about survival rather than become a CEO of a company. To me, my motto became know your enemy. I mean, bronchiectasis were in a way enemies, in a way friends, because I learned how they attack you, how can you treat them. So in a way now I feel more confident, and so this is important to me, because now I know what to do. I know how to handle every time I feel sick, and I can take advantage of that.
Thank you, Sandra, and I'd like to go to Dr. Cohen.
Yes, can you hear me? Yeah. Yes, thanks a lot. So we move on to the next talk, which is about pregnancy and fertility in bronchiectasis by Dr. Leora Boehm-Cohen. Dr. Cohen, is an internal medicine and pulmonologist specialist at Soroka University Medical Center in Israel. She's in charge of the Bronchiectasis and Adult Cystic Fibrosis Translational Clinic, and she's also passionate about bronchiectasis and pulmonary infections. So, Dr. Leora, please go ahead with your presentation.
So first of all, I would like to thank you for having me. It's an honor for me to participate in such an event. Good afternoon to everyone. I guess after these inspiring videos, I would like to share why this issue of pregnancy and fertility, how I got to take care of it. I had a few patients that were just a bit younger than Sandra, and they arrived just past their 30s, and they had bronchiectasis, and one was even attending a pre-transplant clinic, and she came with a notice that she's pregnant. She's 7 weeks pregnant, and what shall we do? And this one thing led to another, and we started getting into things, and we have shared clinic with a gynecologist now, which we can see. So let's see in the next few minutes how this developed. So I don't want to be different than everyone else, but I have also a side of bronchiectasis with a permanent dilation of the airways and mucus formation and a dilated airway. That has a variety of range of symptoms. Some patients will be less symptomatic, some will be more symptomatic, and this is just for yourself a very extreme burden on a patient's life. Now, as women, we like to be best in everything, and so we can have a lot of data here from the United Kingdom data and the EMBARC registry data and the United States registry data that shows that there's a more prevalence of non-cystic fibrosis and bronchiectasis among women more than men. And so looking at the gender differences, we can see also a long timeline. When we look at the pre-puberty prevalence, we have more males than females. But when we go through life, when more post-puberty, adulthood, and postmenopausal women, we see there's a higher prevalence among women, and very high prevalence. The highest prevalence is among women that are over their 60 years old. So this is, and I'm referring to the non-cystic fibrosis bronchiectasis. So exacerbations come to point with a change in cough, more frequent cough, the change in the mucoid in the more purulent or in more viscosity. There can be dyspnea, and there can be fatigue. Now imagine what this does when this happens to almost every patient with bronchiectasis during an exacerbation. Now add to this more another burden or another factor in life, even just having a menstrual cycle. What will happen? There are several factors that are and conditions that lead to an exacerbation. And this is to the great, thank you to the great chapter that was written by Dr. Steinberg and Dr. Perl, that they showed here that predisposing conditions, as discussed, there can be concomitant airway diseases with the bronchiectasis. There can be asthma, COPD. There can be reflux disease, which may be increased in other situations of life. Nutritional deficiencies may add and predispose to exacerbations. Exposure to viral infections. Now, all of these may lead to further exacerbation, which we obviously want to try and eliminate. The treatments, we have the inhaled antibiotics, oral antibiotics, mucoactive agents, and anti-inflammatory agents. All of these are, most of them probably people are familiar with. But then we have several more questions. What do we do now? What do we do next? How does this influence how do I cope with all of this that I have to do? Physiotherapy, there is the best way of treating and avoiding another exacerbation is a postural drainage or an active cycle breathing. Now imagine doing these with a 9-month pregnant. So all of these raise a lot of questions, and we start to have to think about. So we'll start. What happens before? We have a question. The question: what happens with fertility? So there are usually cystic fibrosis male are infertile, but what happens with non-cystic fibrosis bronchiectasis? Well, this depends on the origin and the cause of the bronchiectasis. If it's not a PCD patient and it's just a post-infection, there's no problem with might be no problem with fertility. This is a concern in patients as long as they have lived with the bronchiectasis. We'll start asking questions. Will this affect my offsprings? Another question that is raised. Now, among women, it's about 35% that have subfertility. It's not infertile. And some of this is because of an older age of pregnancy, or if there's cystic fibrosis, then maybe it's more pancreatic deficient. But among patients with non-cystic fibrosis bronchiectasis, there's only a subfertility, and there's not an actual infertility. Now, this can be very worsened by nutrition. And it's not only in cystic fibrosis, but it's also in non-cystic fibrosis patients, because there's dealing with a lot of inflammation, a lot of mucus, and they have to keep in mind all the nutrition status. Now, this is drawn from cystic fibrosis, and we can see that luckily with an advance of therapies and physiotherapy, there are more and more patients who are in pregnant age and fertility age and have more pregnancies. And look at how the numbers rise as we go, which is hopefully need to see if was this a problem. We don't know about patients with non-cystic fibrosis bronchiectasis that maybe they weren't pregnant. We need to ask more questions for that field. So what happens with, well, we are fertile and we have a non-cystic fibrosis bronchiectasis and we have pregnancies, but we have to deal with this changing body all of a sudden. So we have a nice baby and that grows, and the uterus is growing, which has an elevated diaphragm. Okay, so this does add another burden to the breathing. We also have the diaphragm has a normal function, but it is elevated, which adds another burden, another dyspnea, another issue for a patient that has already breathing difficulties, shortness of breath. There's an increased oxygen consumption by the fetus and CO2 production. So all this is another burden. So what we can see here is also an anatomic effect with more airway edema and friability. And I'm going to come into this shortly, but there's also a change in the lung volumes, which has an effect. So what we can also see in the physiological changes in pregnancy is there might be even an upper airway congestion, rhinitis, which is a lot more common, and it can be up to 20% among women. And this changes in just normal pregnancy, which has another difficulty and shortness of breath. Also, there's an increase in minute ventilation due to progesterone hormones. And sometimes there's a balance between hormones that we have to keep in order to see ventilation and mucus clearance. The changes in the other physiological changes, as I mentioned, are the changes in lung volume. And this is on this side, we can see the non-pregnant women. And on this side, we can see the pregnant women at the end of pregnancy. And we can see that there's a decrease of about almost 500 milliliters, but no change in the FEV1. So there is a decrease in lung volumes. We have an elevated diaphragm, and add all this with normal changes, which can be a burden on just a perfectly healthy woman. Add this with bronchiectasis, we need to have something in mind. Keep in mind, what can we do? So we recommend that a follow-up would be with a multidisciplinary clinic. Well, because if a woman will have to start running along with her for her gynecologist, her pulmonologist, maybe advise with an anesthesiologist, what should I do towards labor? What can I have, not have? A physiotherapist. We want to keep going on with physiotherapy. We want to keep avoiding exacerbations. And therefore, we need to try and adapt to all of these. So our experience led to a multidisciplinary clinic, which maybe we should give a thought about and try and have more access instead of running to several specialists, and try and figure out for an individual how to go through the pregnancy, through the labor, and so on. So what about the treatments? We know we're supposed to take our treatments, saline, mucolytics, maybe inhalations. Are they safe? Are they not safe? What should we do? So there's a great task force it was published in the European Respiratory Journal that kind of summarized it, the most common therapies. And there's no problem. Most of the therapies are compatible during pregnancy and are safe, as is hypertonic saline, which is very important. There's no problem not during any term of pregnancy or during labor or breastfeeding. So we need to continue with these. Now, what about vitamins? All are no problem. They're probably safe and compatible. The gastroesophageal reflux, which we know is a predisposing factor, we would like to continue and have treatment of the reflux disease, and there's no problem with the commercial preparations. It's safe to be continued during pregnancy. Now, a very question is about antibiotics. So the inhaled antibiotics are safe. There's no problem during breastfeeding or during labor, and tubermycin is completely compatible and safe in all stages of pregnancy. And there was a bit concern about colistin inhalation, but there is scarce data in humans, but it's probably is safe and not and there's not any congenital defects that are seen with its use. Ciprofloxacin here, which you can see. Well, this is a bit debated because in general, physicians usually want to avoid during pregnancy and lactation, but the human data that up to date, the known, there's probably a low risk. So if someone knows that it's an antibiotic that is sensitive with the microbiome is sensitive to, it's probably safe if there's an exacerbation, especially if it's more severe exacerbation, to actually use this antibiotic. But what else can we do? So we still want to do physiotherapy. We still want to keep doing our physiotherapy, and it's so important, but we just have to try and time it Okay, if we're going to have a meal and we have a reflux, which is increased during pregnancy, we would probably want to change the time and try and do our physiotherapy before our meals. Also, there's a burden on the pelvic floor and there's a lot of cough. We would like to prevent future complications. So we would try and work on that as well. What else can we do? We can have smaller meals. It seems very obvious when we say it, but we should try and remind patients that is something that we can do. Just to have smaller meal, change the time of the physiotherapy and adapt physiotherapy. Sometimes when fatigued, it's not easy to have the active cycle breathing and the postural drainage. It's not so easy to do so even physically. And therefore, we're going to have to try and adjust and maybe consult with the physiotherapy or have more mechanical or more active physiotherapy. Also, another concern is the glycemic control that can add and have more burden. So we have to keep that in mind also. What about during labor, where patients would say, oh, we had several debates with several anesthesiologists that they say, no, this patient is too ill. We don't want to take any risk. Let's have an operation. But an operation or a cesarean section to deliver is not exactly the option that we would think as a pulmonologist, or because we want to think a patient to be more mobile after labor, to have the ability to continue and have physiotherapy, which has a lot of stress also on abdominal muscles. Okay, we have the stomach. If we have a section, if we have a post-operation in the stomach, it's pretty painful to have and continue the physiotherapy. So what we usually advise, and we of course extrapolate from cystic fibrosis, but I think it concerns especially knowing that patients with non-cystic fibrosis bronchiectasis have to have their physiotherapy and airway clearance properly. So we have to have a multidisciplinary planning. The preferred way would be epidural anesthesia, where there's enough pain control and enough control of the female that she's able to participate, able to have the cough if she needs, able to take out mucus if she needs, not laying down on the back, okay, just completely on the back. And if needed and something goes wrong, it's easy to come to move on to a lumbar, which is an anesthesia that is more more intense and can lead and can have, with that, we can have a section if needed. We would like to avoid systemic opioids to relieve the pain, because these can lead also to suppress the ventilation and lead to bowel obstruction, which can further have more complications and lead to less ability to have physiotherapy, mucus clearance, okay, and airway clearance, which is much important for patients with bronchiectasis. Now, these are numbers from the cystic fibrosis severity after what happens after the labor and outcomes. And we can see that in patients with a lower lung volumes, long FEV1, there are more premature births and a lower birth weight. But we still lack data and enough data what happens with other bronchiectasis. In our experience, which is a very small experience, there was only one patient out of 5. Okay, I'm putting that we had, and up till now we only had one that was preterm. And the rest were at term, and beautiful babies, and they came to the follow-up after labor, which was amazing. And the pregnant, and they even had selfies from the labor, and it was amazing. But we do need to keep in mind that we have to have more data on for these patients and how we can treat, or maybe even have special groups to teach patients during labor and pregnancy. There are all kinds of, I don't know, Pilates groups for pregnant women. Let's have groups for bronchiectasis women. So what happens after? Is there any effect? So we don't know enough on the effect of the lung volumes in patients with non-cystic fibrosis and bronchiectasis, but we do know what we can see here in these lines, that in this from this great paper, that there are periods before, during pregnancy, and after. And if the severity of the disease, if the severity of the disease of cystic fibrosis is worse, the moderate or severe disease, there is a decrease following in the FEV1, whereas the main decrease in FEV1 is before the pregnancy and during and the timeline between 1 and 2, before and pregnancy, and there isn't a further decrease after labor. But this is in need of more investigation. What happens to the lung function and lung volume among patients with bronchiectasis? So we matured a bit, and we arrived at menopause, and hopefully we have more and more women, although there are more women that might be more ill in menopause. And we know that postmenopausal women are very infected with increased prevalence of non-tuberculous mycobacterium and more prevalent. But there are some suggestions that the androgenous female hormones have some protective role against the bronchiectasis, and patients who had an early menarche or had more time with the estrogen probably have, but there are conflicting evidence in that fact, so we have to be careful with that. During menopause, we do have a different microbiome we have to keep in mind, and to try and treat according to the factors, as we saw an increased prevalence of non-tuberculous infections, and we have to keep that in mind. And postmenopausal women have to culture properly, have a mucus culture as well as known, and if there's more exacerbation, to try and figure out if there's another factor that is causing the exacerbations. Another thing that was a bit mentioned before, we have also the urinary incontinence. Okay, there's because of the coughing and the pelvic floor. So we have to keep in mind and add maybe physiotherapy that is more in mind of this age and the needs of patients in this age. And I guess that what I was trying to say is that we need to keep in mind that there is a gender difference, and there are parts in life that we have to keep in mind and try and figure out more data, more maybe attention to be given to these patients. And I guess that together, if we think together, and as I was learning a lot from my patients, we can share together. So thank you very much.
Thanks a lot, Dr. Cohen, for your wonderful presentation. And next, move to the last presentation of the seminar, which is about bronchiectasis in older age by Dr. Andrea Gramegna. Dr. Andrea Gramegna is assistant professor at Milan University and a consultant in pulmonology at the Policlinico Hospital in Milano. He has spent a large part of his clinical activity in one of the largest bronchiectasis programs in Europe under the mentorship of Professor Stefano Aliberti in Milano, and has contributed to clinical and translational research in bronchiectasis. Dr. Gramegna is involved in the creation of a research network of non-tuberculous mycobacteria infection in patients with bronchiectasis. So Andrea, it's your time. Go ahead with your presentation, and thanks a lot in advance.
Thank you very much, Oriol, for this presentation, and I'm very happy to be here and take part of this really interesting day focused on bronchiectasis. Thank you to the European Lung Foundation. I hope my slides, you can see my slides well, and if there is some problem, please write. Okay. In the next 15 minutes, I will try to show you how bronchiectasis can matter in the elderly during this later phase of life. And first of all, it's time for a definition. When we talk about bronchiectasis, and I'm sure the most of you are very well aware about it, we talk about a chronic respiratory disorder where we have chronic respiratory symptoms, chronic cough, sputum, frequent exacerbations such as acute bronchitis, in the context of radiological finding of enlarged bronchi, what we call bronchiectasis. Over the last 10 years, over the last decades, we have been very well aware that bronchiectasis is far more common than we previously thought. This is a cornerstone study, from the UK scene, showing estimates of the incidence and prevalence of bronchiectasis in the UK, in this case, over time. And the authors demonstrated that epidemiology of bronchiectasis increased year by year during the study period from 2004 to 2014. But we can move next to say that it's not only true that bronchiectasis are more diagnosed year by year due to a lot of reasons, including that physicians are more aware about the clinical burden of bronchiectasis and their existence as a disease itself. But we can also show, we can also study through epidemiological reports that incidence and prevalence of bronchiectasis increased with age, from a lower burden, a lower epidemiological burden in the young adult age to the highest incidence and highest prevalence after the 65 or even the 75 years of age. So bronchiectasis are very common, especially in the elderly. And then we can have a question that is, who are those people with bronchiectasis in the elderly? And we can try to find an answer looking through some cohort study, retrospective or prospective observational study. And this is one of them. This is a multicentric study enrolling about 1,200 patients with bronchiectasis. About 20% are more than 75 years old, and we see that we can understand that this particular subgroup of patients with bronchiectasis, elderly patients, are more comorbid, that is to say, have more concomitant conditions and more impact from existing underlying comorbidities, had lower lung function and lower performance status. Lower body mass index is also a good indicator of some frail condition of frailty, and so they were more frail than the other groups, and they had also worse bronchiectasis endpoints, such as increased frequency of exacerbation, increased frequencies of hospital admissions, and also worse quality of life. So the first two key points of my speech are that bronchiectasis are more frequent in older patients, and that older people with bronchiectasis have, in many cases, worse clinical outcomes and decreased quality of life than the other individuals with bronchiectasis. But then we can go further in our discussion, and I will try to show you the effects of aging on the mechanism that are at the base underlying the bronchiectasis disease. We know that etiology, that is to say, causes of bronchiectasis, are very heterogeneous. But if we want to divide etiologies, we can use these classes. It's very simplified, but I think it's useful to better understand my point. We have bronchiectasis coming from these different pathophysiological mechanisms: acute airway insult, reduced immunity, or following chronic airway inflammation. And I will show you that all three, these mechanisms, the three different mechanisms, are getting worse in the elderly, in this later phase of life. And so people in the elderly have more reason, more risk to develop bronchiectasis, or if they have bronchiectasis, it may get worse due to age. First, acute airway infection or inflammation. Usually we have bronchiectasis in this case due to acute lung infection. In most of cases, we have localized bronchiectasis, as you see in this CT scan. And a lot of infectious events, such as pneumonia or other severe airway infections, can cause bronchiectasis. And we know that pneumonia and acute respiratory sepsis are more common, more frequent in the elderly. And so older patients are at higher risk of post-infective bronchiectasis. But then we should also stress this point that localized bronchiectasis can also raise a suspicion of aspiration. That is to say, aspirated of a foreign body, in most of cases, food, we say bolus. And older patients, due to several reasons, including some compromised deglutition, may be at higher risk of also post-aspiration bronchiectasis. But then a very relevant field of pathophysiology of bronchiectasis in the elderly is immunosenescence. This is a difficult word to say, that during aging we can have a gradual deterioration, a gradual step-by-step worsening of immunitary system, both in terms of host defenses and also in a compromised long-term immune memory. We get vaccination to have immune memory, but in the later phase of life, during the elderly, this immune memory can work worse. And this is a first mechanism that can lead to bronchiectasis or bronchiectasis deterioration during the elderly. But we have also another very relevant issue in this phase of life, that is that older patients may have some concomitant conditions as inflammatory disease or malignancies, that is by itself a possible cause of immune compromission, or they may undergo elder people with bronchiectasis may undergo some immunosuppressant drugs, such as cytotoxics, chronic corticosteroids, for treatment of other conditions, including inflammatory malignancies, but also these drugs, also these therapies that might be very useful from one side can lead to immune suppression from the other side. And thus, many individuals may develop bronchiectasis in this later phase of life, or if they have bronchiectasis, bronchiectasis can be very difficult to be managed by physicians. And then chronic airway inflammation, that is a bit more controversial, but one of the most relevant area talking about the genesis of bronchiectasis. We know that the risk to develop chronic airway inflammation, for instance, in the context of COPD, is very common, at least for smokers or ex-smoker, formerly smokers, and increases with age. And we know also that there is a huge overlap between COPD and bronchiectasis. We have estimates that almost 50% of patients with COPD attending our clinics have concomitant bronchiectasis, because both bronchiectasis and COPD, and in a lesser extent bronchiectasis and asthma, share, at least historically, the same neutrophilic model of airway inflammation. And so during this phase of life, especially for people with an underlying respiratory condition such as COPD or asthma, the risk to develop bronchiectasis is higher than people in other ages. But in this case, we should also remind that we have bronchiectasis following gastroesophageal reflux disease. This is a bit more controversial. Some authors suppose that reflux disease is the main cause of bronchiectasis. Some other authors talk about reflux as a predisposing conditions or precipitating conditions for bronchiectasis worsening, but we should be aware that long-term exposure to gastroesophageal reflux disease may cause or may decompensate bronchiectasis. And so if we look at bronchiectasis in this later phase of life, we may have a different portrait, a different picture of the most relevant etiologies and the most relevant concomitant mechanisms that we as physicians should be very well aware and should try to interfere, should try to work with. In most of cases, we will have bronchiectasis and COPD, bronchiectasis and immunodeficiency that in older patients are likely to be the main and the primary mechanism of bronchiectasis development and progression of disease. And in these last minutes of my speech, I will try to go further and try to show you that the effects of aging in bronchiectasis can be deleterious not only on the traditional mechanisms, pathophysiological mechanisms that we associate with bronchiectasis, but we have a lot of other age-related comorbidities or age-related conditions that may have an impact on bronchiectasis clinical management. And I will give a mention of cardiovascular events and malignancies. First, it's very difficult to define what is a comorbidities, a concomitant conditions, a concomitant disease in patients with bronchiectasis, because we may have an overlap between causative mechanism, causative disease, and coincidental disease. But I will show you that we may have different clinical entities sharing the same underlying pathophysiological processes with bronchiectasis. And cardiovascular disease is, in my view, one of the best examples, because both bronchiectasis and cardiovascular disease may share the same predisposing condition, the same risk factors, that is chronic inflammation. And so we have chronic inflammations in both people with bronchiectasis and people with cardiovascular disease. We know that we have higher prevalence of cardiovascular events in people with bronchiectasis, and some authors at least look at bronchiectasis to be an independent factor for risk factors for cardiovascular risk. So we have a strong need now for a better epidemiological understanding of the role of inflammation and cardiovascular disease in bronchiectasis clinical management. That is, first of all, very important in these patients, in the elder individuals, where also in the general population, cardiovascular disease are more frequent. And then a same mention to malignancies. We know that people with bronchiectasis, and both people with bronchiectasis and people in elder population, have an increased risk of developing solid organ malignancies, first of all, lung cancer. This understanding comes from some retrospective studies, so it's not so strong, but it's quite strong to be taken into our clinical consideration. And we know also that diagnosis and also treatment of these conditions in patients with an underlying respiratory condition may be a great challenge. So also in this case, we have a sort of alert, and we should take care of screening our patients. And this is true also for other age-related conditions, age-related comorbidities, that may have an impairment of the performance status, and as in the case of osteoarthritis or anemia. This can get daily physiotherapy and daily exercise even more difficult, or also some mental issues, as in the case of anxiety and depression, that are very relevant if we talk about adherence to a very maybe heavy burden of care, as for many of our individuals with bronchiectasis. So the last key points of my speech are that older people with bronchiectasis also face all those health issues that are related to aging, and that bronchiectasis issues and age-related health issues can be really burdensome for these individuals. Especially cardiovascular disease and lung cancer may be a common complication for this group, and so we should be very careful and very aware to do the best in terms of screening and prevention for our patient in this phase of life, in this age, this phase of their life. Thank you for your attention.
Thank you very much, Andrea, and thank you very much, Sandra and Leora, for your amazing presentations in this last part of the seminar. We have around 10 minutes for questions and answers, and we are lucky that we still have Ed with us. And I'd like to start with a question for Ed. That is, Ed, how well prepared do you feel to manage your bronchiectasis as you're getting older and more independent? For example, in going on trips away from home, or thinking in going to university. What do you think, Ed?
I think that it will be different, but I think the things that my parents and I put in place will really help. So I know the factors that cause me to have exacerbations, and I also know the symptoms that I normally have. So should it be staying in the damp or staying in the cold, and then also showing maybe a change in behaviour and also an increase in coughing. I also think that I can do a lot of independent physio as well, especially with the trumpet, as long as I keep it clean, to stop the pathogens building up inside. And also doing a lot of exercise, so running and cycling. So I should hopefully be able to keep myself healthy as I grow up and become more independent.
Thank you very much for your example and for your positive way to see the condition. As Sandra, I also have a question to Sandra, and I'd like to thank your positive way to understand your condition. I'd like to know, as a medical doctor, what's your main preoccupation in your day-to-day? What worries you most about your condition?
It's not a simple question to answer. What worries me is mainly other people's attitudes, because with COVID, for example, people were more, aware that risks were around, so we used to wear masks to go around, and I still do. So to me, I try to do the best for myself, but I cannot predict other people's behaviors. So what scares me is, for example, about traveling. I keep traveling, but I see on a flight, no one wears a mask. And I find it a little stupid, let me say, because we all know that COVID is still around, and not only that, and close environment like airplane should be mandatory anyway to wear a mask. So basically, what frightens me is other people that are not caring about each other. That's the answer.
Okay, thank you very much. Alan, do you have questions?
Yes, I do. So we've heard from Ed and Sandra, and I can add to my personal feelings how long it takes for the diagnosis, but we heard from Professor Kantar the importance of the treatment starting as soon as possible. In the current thoughts and guidelines, we know how to get a diagnosis. Is there going to be an ideal time to get it, to bring it forward? Because it seems to take forever to get from first turning up to the diagnosis, and that's a question to our medics. Apparently not. So I have a question on the male infertility in Dr. Cohen's talk. As a patient with bronchiectasis and infertility, my experience is it's actually quite common amongst male patients with bronchiectasis, the infertility, particularly if they've got it at that age where they're trying to be a father, it is quite a major part of the disease function. Do you have a comment, Dr. Cohen?
The question is if there's infertility or what to do.
Yeah, well, is there infertility amongst the males, and is there anything you can do?
So first of all, there might be infertility. First, there's a lot of concern about transmission of certain diseases. So genetic consultation is very important before conceiving or thinking of these issues. And another thing that can be done is there are fertility clinics, especially male fertility clinics, that can be done as sperm count and cilia, cilia, to see how it works and how the sperm is viable. And then the clinics may help if there's only subfertility and not completely infertile. We do have a clinic in our center, and I know there are several such clinics. So it depends again on the cause. But if there is such concern, we do recommend a consult of also these clinics. If that was the mention.
Yes.
So there's a question.
Yes, I have a question to Dr. Gremekna. I see in the seminar chat a lot of preoccupation about the comorbidities and bronchiectasis in the older age. I'd like to ask you, which are your recommendations to have a good quality of life in older people with old people with bronchiectasis and comorbidities?
Yes, but in terms of comorbidities and bronchiectasis, in my view, the best approach is to have a sort of personalized approach. And because bronchiectasis can get some of your comorbidities worse. And on the other hand, if you have an uncompensated comorbidity, it can be more difficult for you to manage at the best your bronchiectasis. So with the help of your physician, it's better to screen for the situations that are more likely to happen according to your risk factors and for your age of life. And then you can face both the clinical management of bronchiectasis and the correction of some risk factors of some, and the management of some comorbidities. It's true for across all the ages. If we have people with some clinical syndromes and bronchiectasis, we have comorbidities, and bronchiectasis, we have extra respiratory and respiratory involvement. And of course, it's true for the elderly, because it's by itself a condition of a moment of your life where you are more at risk for some disease, or you have a different performance status in some case. So the better to do, in my view, is to screen with your physician and your multidisciplinary team for the comorbidities you are more at risk.
Okay, thank you very much. There's a lot of questions in the questions and answers panel that we'll try to answer later, and we are on time and we have to move to the take-home message by Michelle and Maria. Thank you very much to all of you.
So just a final wrap-up message from a point of view of a patient. I think one of the most important messages that I take home from this conference is that bronchiectasis is not just a disease that affects your lungs, and that you have to have a proactive approach and think about your nutrition, think about exercise, think about airway clearance. Also, take good care of your mental health, stay educated, read about it, and find adequate care. And I'm fortunate enough to have an excellent chest physician that takes care of me here in Lisbon. And I just hope that everyone should really have that opportunity everywhere they live in the world. And also, I have to say that finding a support group of patients with the same condition is very important. And I found this group amazing. So I strongly recommend that in each of your countries you find a support group that provides you with a group chat, and I strongly recommend it. So thank you so much to everyone involved, to all the clinicians and all the patients and physiotherapists. It's been amazing. I hand over to Mikhail now.
Yeah, thank you, Maria. I think this day was amazing, and one thing that I took from it is the importance of a strong support group. So try to find yours on social media or other support groups, because it's really important. I also like the comments in the chat. I'm 85 and still going strong, and all these remarks. So I'd like to thank all of the speakers, all of the patients, contributors, the session chairs, the EMBARC Steering Committee, and the Bronchiectasis Patient Advisory Group, and everyone who's helped to promote the event. And also to all of you asking these wonderful questions on the chat and the Q&A. Stay in touch. We have been reminded throughout the day that these talks will be recorded, and also the Q&A session. And we'll notify all of you by email, all of you who have registered by email, regarding when the recording will be available. So with that, we will close this amazing event and see you all next year, when we plan to have another similar, the 4th Bronchiectasis Patient Conference. Have a good rest of the day, and we'll hope to see you again